Okay, continuing on with the Certified Medical Reimbursement Specialist test prep, we're looking at general. In general, the questions are over the entire study guide for these. Uh, you're going to see a lot of the questions that I came across in this particular section has to do at the end of how fees are determined, the practice management, just individuals. They've got questions at the end of each section. We've got a lot of those questions on the test. So again, there are 41 questions, so you just want to take your time, review, and use critical thinking skills. Practice management. Practice management, we think of managing a doctor's office. So the practice management software is going to deal with not only the EMR, but the documentation as far as coding software, billing software. So it's going to be an all-inclusive software that deals with a lot of it. It doesn't mean necessarily you're not going to outsource either the coding or the billing. It just means that you can control all of the information within one system. So it's all the parts of the practice. It's everything from patient care to the forms, regulations, as well as actual reimbursement billing cycle. Key points. These key points are located under how the fees are determined. So you've got healthcare providers are reluctant to discuss fees with each other due to the competition and possible legal action based on conspiracy. What that means is because their fee schedules can fluctuate, one doctor could bill more than another. And if they did talk about the fees, it looks like one doctor may be under pricing fees to get more people in the door. So they don't really talk a lot about that. So you also have Medicare's fee schedules. Texas is the only one that doesn't allow multiple fee schedules. They have one state fee schedule. Private carriers, number 2, private carriers do not release information on fee profiles, relative values, or conversion factors because they don't want the provider to charge more for a service if he or she is not now charging the maximum allowed. So they don't want them to change their fee schedule based on providing those prior to enrolling in those services. Medicare fee schedule is based on the resource-based relative value scale, the RVS. It's steadily being adopted by more carriers. So we are trying to see a stabilization of fees. Number 4, charging fees that are less than the amount allowed by an insurance carrier only benefits the carrier itself and not the provider. Okay. Number 5, insurance carriers may be paying your provider 20 to 50% less than they are paying your provider's colleagues for the exact same service, simply because your provider has not yet set the right fee. So if you do change doctors, that's one thing to keep in mind, that one doctor may charge less. Insurance company pays more to one than another, which would actually ultimately change the amount that would be out-of-pocket expenses for the insured. All medical fees are negotiated down or discounted either voluntarily or involuntarily. And then finally, regular fee schedule management puts your provider in control of reimbursement. So you should at least every year look at the current fee schedules, what you got paid by insurance carriers. If you are going to renew those contracts, you need to update your fee schedules. And then our fee schedules, again, the doctor can have their fee schedule on the amount that they want to bill. Each carrier is going to have their maximum allowable amount for the fee schedule. So determining the fees is going to be based on how the carrier pays, such as Medicare does an 80-20 split of their allowable fee schedule. So again, depending on if you have employee or group health, if you are self-insured, so forth, can you balance bill for those fees? For employer group health, that's normally you as a provider or billing, you accept that fee as paid in full. So there is no balance billing. Again, testing tip for this, a lot of the questions that are at the end of each section are located on the test. So you can review that for the answers. Dealing with appeals and rejections, as far as that goes. In CCI edits, there are a hyperlink in your certification for you to review and get to the CCI edits. So again, that's going to show the unbundling. You may or may not be able to do that. Claims processor, their goal is to get the claim paid properly. And then 30 to 35% of paper claims are rejected. These numbers are on your certification. They're wanting you to show that you understand that there is a denial and a rejection amount. 50% of denied claims are paid after appeal. So if you do have a denied claim, you don't want to stop there. You do want to appeal it to get it paid. That's where some actually lose money because they fail to appeal. Denials account for 20 to 40% of the revenue cycle cost. So what that means is the amount of time and energy that your staff is putting towards these denials account for 40% up to 40% of that cost of the budget. Two categories of claims denials. We have missing or incorrect information. Normally, it's not caught before it's rejected, and then policy coverage and non-coverage issues. So even though it may not have been rejected in the initial editing scrub portion, it doesn't mean it's not going to be denied. So rejection is before it ever gets to the payer. So the clearinghouse can reject it. You can find it on your end, which means we need to do those corrections, and then you can resubmit it. If it makes it through the rejection, the scrubbing portion, and it makes it to the carrier and they deny it, it is a denial at that point, but it could be for missing or incorrect information that wasn't captured beforehand. So common reasons for rejections. That's one of the things that they're going to have you like true, false. Is this a reason for rejection or is this a reason for denial? So reasons for rejections, you could have missing or invalid insured ID or social security numbers. So again, this is before it gets to the carrier. Missing invalid insured policy group numbers, incorrect dates, missing physician or supplier signature, medical necessities not supported, incorrect procedure codes, missing I-10 codes. There's no diagnosis listed on there. Missing provider ID numbers, missing drug equipment or supply information, unclear documentation. So applies to the paper claim. If they're filling it out by hand still, you can't have poor handwriting and you can't use whiteout on there. And then multiple visits on the same day, not documented. Keynotes here, you want to remove any types of questions by the carrier to prevent rejection or denials. If it doesn't look right, it probably isn't, meaning if there's something that's off about the claim, then it's probably wrong. You need to review it and correct it. You have 50% change. It should be chance of getting a denied claim paid with appeals, and then not all claims can be appealed. So if they don't have policy provisions for that particular thing or they lack coverage, you're not going to get that claim. It's going to be denied. So then at that particular point, do you balance bill or do you go after the patient? So again, if it's Medicare, you have to have an ABN signed, meaning that the patient was aware that they were going to be billed for that. If you don't, then you have to eat the cost. Okay, questions. There's 2 question examples here. We have multiple visits on the same day without documentation would likely cause a claim to be paid, pended for additional information, or denied. And then second, as a claims processor, your main goal should be to get the claims paid as accurately and promptly as possible. So we would have multiple visits, and that was the one, if we don't have documentation, we're going to get that denied. And then, yes, your main goal is to get them paid accurately and promptly. So that is true.